Celiac disease in primary care. This presentation is about celiac disease in an adult patient. This educational module has been developed for healthcare providers in primary care, physicians, nurse practitioners, and physician assistants. The goal of this educational program is to increase health professionals' awareness and knowledge of celiac disease in an adult patient, to improve the diagnosis rate and management of this condition. The author of this presentation is Renata Zink. Renata Zink is a family nurse practitioner. She is currently employed by a private hospital in New York. Renata is pursuing her doctorate of nursing practice degree at Evelyn Spiro School of Nursing at Wagner College in Staten Island, New York. The narrator is April Lillard. April Lillard studied theater at Wagner College in Staten Island, New York. She graduated in May 2018 with a BA in theater and speech, with a concentration in performance. After completion of the presentation, the healthcare providers will have the knowledge to understand the risk factors for celiac disease, differentiate between celiac disease, wheat allergy, and non-celiac gluten sensitivity, recognize the manifestations of celiac disease in adult, identify diagnostic methods, discuss the dietary management of people with celiac disease, and explain the complications of untreated celiac disease. Celiac disease is an immune-mediated systemic disorder triggered by dietary gluten in individuals with genetic predispositions. Those are individuals with HLA-DQ2 and HLA-DQ8 haplotypes. Ingestion of gluten triggers an autoimmune reaction, which results in destruction of the villi in the small intestine. Celiac disease can affect any organ in the body, including central nervous system, skin, joints, teeth, and even bones. Patients may present with variable symptoms. Those symptoms can be typical gastrointestinal symptoms, such as bloating or diarrhea, but can also be atypical, such as skin rash or iron deficiency anemia, in which case the healthcare provider may not think of celiac disease, which consequently delays diagnosis. The symptoms can range from mild subclinical disease to severe life-threatening. It is commonly thought that celiac disease is the diagnosis of childhood, which is not true. Celiac disease can occur at any age and affect any ethnicity. It is diagnosed by the presence of typical celiac autoantibodies and intestinal biopsy. Celiac disease is characterized by the small bowel inflammation, villus atrophy, crypt hyperplasia, and infiltration of intestinal mucosa with intraepithelial lymphocytes. The picture here shows the normal villi and the complete flattening of villi due to celiac disease. The loss of absorptive surface area due to villus atrophy, injury of the small intestine, and deficiency in digestive enzymes are the cause of malabsorption of vitamins and nutrients necessary for survival. Celiac disease affects about 1% of the population worldwide. The prevalence has been increasing globally and varies significantly depending on geographical location. In the United States, prevalence has doubled in 15 years, and prevalence has increased more than fourfold in about the last 50 years. There is a higher prevalence among non-Hispanic whites comparing to African Americans. The highest prevalence of villus atrophy has been seen in descendants of Punjabi area, comparing to other ethnic groups in the United States. National Institute of Health reports that 1 in 141 Americans has celiac disease. It is about 3 million people nationwide, and many of them don't know it. The table here represents global celiac disease prevalence by continent and geographical region. Celiac disease has been reported worldwide. The pooled global seroprevalence of celiac disease was found to be 1.4%. The seroprevalence of celiac disease was observed to be the highest in Asia at 1.8% and the lowest in Africa at 1.1%. In Africa, the population prevalence of the HLA-DQ2 haplotype and wheat consumption are significantly higher in the northern Africa compared to the sub-Saharan Africa. Therefore, most likely the majority of the sub-Saharan population is less susceptible to celiac disease than northern African population. The countries that had the highest seroprevalence were Algeria, Czech Republic, India, Israel, Mexico, Malaysia, Saudi Arabia, Sweden, Portugal, and Turkey. The pooled global prevalence of biopsy-confirmed celiac disease was 0.7%. Celiac disease was found to be 1.5 times more common in females than males, and about twice more common in children than adults. As we can see, there are large variations in the prevalence of celiac disease based on geographical location. What are the factors responsible for those differences? The researchers report genetic and environmental factors, including the rate of wheat consumption, age of wheat introduction, infant feeding practices, gastrointestinal infections, the use of antibiotics and proton pump inhibitors, and cesarean section rates. Some people with certain conditions have a higher risk for developing celiac disease comparing to the general population. The risk is higher in individuals with type 1 diabetes, autoimmune thyroid disease, autoimmune liver disease, Down syndrome, Turner syndrome, Williams syndrome, IgA deficiency, IgA nephropathy, and juvenile idiopathic arthritis. So testing for celiac disease should be considered in those individuals. The first and second degree relatives are at the highest risk for developing celiac disease. The risk is highest among monozygotic twins at 75%. Then, human leukocyte antigen matched siblings at 40%, and other siblings at about 20%. Risk in other first-degree relatives is about 10%, and the risk is lowest in second-degree relatives. The most important genetic risk factor for celiac disease is the presence of HLA-DQ heterodimers. Almost all patients with celiac disease have HLA-DQ2, HLA-DQ8, or half HLA-DQ2 genes. More than 90% of people with celiac disease are DQ2 positive, and most of other individuals are DQ8 positive. Although 40% of the general population carries those genes, and the presence of those genes is necessary to develop celiac disease, only 2% to 3% of HLA-DQ2 and HLA-DQ8 carriers will develop celiac disease. The major environmental factor is gluten. The presence of both genetic predisposition and ingestion of gluten is not enough, however, to develop celiac disease. It is not clear why some of the individuals who are born with the genetic susceptibility to celiac disease and have been ingesting gluten since infancy do not develop celiac disease until late in life. There are other environmental factors involved, and their presence sets off the immune response to subsequent gluten ingestion. Swedish epidemic that occurred between 1984 and 1996, during which the incidence of celiac disease greatly increased, gave rise to the hypotheses as to the infant feeding practices and breastfeeding as additional environmental causes for celiac disease. The studies, however, did not confirm that breastfeeding has an effect on development of celiac disease. The timing of gluten introduction was not found to have a significant effect on development of celiac disease either. The high amount of gluten in child's diet may be a possible risk factor. The repeated gastrointestinal infections, rotavirus infections in children, and Campylobacter infections in adults are considered to be risk factors. Having enteritis at the time of gluten introduction was proposed as a risk factor. Some other risk factors are medications, particularly antibiotics and proton pump inhibitors. The microbiome may play a role in development of celiac disease. Microbiome usually refers to bacteria, viruses, and fungi that inhabit our body. Most of them are found in the gastrointestinal tract. Studies have indicated that patients with celiac disease have changes in their microbiome. Although in the past celiac disease was considered a wasting disease affecting mostly young children with the classic presentation of malnutrition, failure to thrive, abdominal pain, diarrhea, and muscle wasting, it is not the case presently. Today, studies have demonstrated that symptoms of celiac disease have shifted to non-classical symptoms such as iron deficiency anemia, osteoporosis, bloating, constipation, headache, and abdominal pain. The majority of patients are diagnosed late in life, between their fourth and fifth decade. The majority of patients manifest silent presentation. They may not have any gastrointestinal symptoms, but experience complications of the autoimmune damage elsewhere in the body caused by undiagnosed celiac disease. Although the prevalence of celiac disease has been increasing, the diagnosis rate is still slow, rendering celiac disease one of the most underdiagnosed autoimmune disorders. It takes approximately 13 years from the appearance of symptoms to diagnosis. In the United States, more than 80% of people were undiagnosed in 2009. I want to mention here a few reasons for underdiagnosis and delay in diagnosis. Celiac disease is still perceived as rare, therefore healthcare providers tend not to look for it or screen it. Healthcare providers are still looking for symptoms of diarrhea and malabsorption, but most people do not have classic symptoms due to a shift in symptoms to non-classical symptoms and to the silent form of celiac disease. Celiac disease is also difficult to diagnose because patients may present with diverse features to many subspecialties, and this further delays diagnosis. Healthcare providers need to have knowledge that joint pains, osteoporosis, ataxia, or neuropathy could manifest celiac disease and in many patients be the only findings. On a positive note, the diagnosis of celiac disease has improved in the recent years to less than 50% in 2013 and 2014. The increase in diagnosis could be attributed to the increased awareness of celiac disease, as well as the increased public interest and adoption of gluten-free diet. When celiac disease is not diagnosed and not treated, the affected individual may suffer complications such as anemia, peripheral neuropathies, dermatitis herpetiformis, depression, osteoporosis, infertility, and malignancies. The risk of malignancy doubles in people with celiac disease. There is an increased rate of esophageal carcinoma, small intestinal adenocarcinoma, non-Hodgkin's lymphoma, and melanoma. It takes 5 years of strict adherence to gluten-free diet to level this higher rate back to the general population's rate for most of those cancers. Disease process begins with gluten. Gluten is a storage protein found in wheat, barley, and rye. Gliadin, which is the component of gluten, is responsible for the immune reaction in genetically predisposed individuals. When gliadin enters the small intestine, it is very difficult to digest, and as a result, long polypeptides remain in the small intestine and cannot be completely digested. Those gluten fragments that cannot be digested cause epithelial cells in the small intestine called enterocytes to release protein zonulin. Zonulin loosens tight junctions between enterocytes. It is seen here at 1. When we move to 2, tight junctions are open, which allows gluten fragments to cross the intestinal lining. As a result, inflammatory cells are activated and release cytokines including interleukin-15 that cause innate immune inflammation. Interleukin-15 induces intraepithelial lymphocytes, which are directed against enterocytes and cause damage to the intestinal lining. In addition to the innate immune response, the adaptive immune response takes place. In 3, we can see damaged cells release enzyme tissue transglutaminase 2, which deamidates gluten fragments. Deamidated gliadin then binds to HLA-DQ2 or DQ8 molecule on the antigen-presenting cell and is presented to the helper T cell we can see here at 4. This process triggers the production of antibodies against tissue transglutaminase, gliadin, and endomysium. Measurement of those antibodies in the blood is the part of the process of diagnosing celiac disease. T helper cells further stimulate killer T cells to directly attack enterocytes at 5. Activated inflammatory cells further cause local inflammation in the small intestine, which causes the gastrointestinal symptoms. They also migrate to the other parts of the body, where the inflammatory processes cause the extraintestinal symptoms seen at 6. Gastrointestinal problems occur more often in younger children. Children younger than 3 years may have diarrhea, poor appetite, abdominal distension, and impaired growth. Older children and adults may report diarrhea or constipation, abdominal distension, bloating, and weight loss. Patients with celiac disease can present to the healthcare provider with many extraintestinal manifestations. Anemia is the second most common symptom of celiac disease in adults after diarrhea. It affects 15% of patients. Iron deficiency anemia is more common since iron gets absorbed in the proximal portion of the small intestine, where celiac disease does most of its damage, followed by folate and vitamin B12 deficiencies. Anemia in celiac disease is caused by the malabsorption of nutrients and also by the chronic inflammatory processes. Patients presenting with anemia as a main symptom had more severe disease as compared to patients who presented with diarrhea. Healthcare providers should raise suspicion of celiac disease in adult patients when patient presents with iron deficiency anemia. Another red flag for healthcare providers raising suspicion for celiac disease is no response to oral iron supplementation. As per US and UK guidelines for gastroenterologists, all patients with iron deficiency anemia should be tested for celiac disease. Osteopenia and osteoporosis are very common in adults with celiac disease. Osteoporosis in celiac disease is caused by malabsorption of calcium and vitamin D. It leads to increased fracture risk. The treatment is gluten-free diet. Some patients may require supplementation with calcium and vitamin D. Patients who present to the primary care with reduced bone mineral density, unexplained by age or other factors, should be screened for celiac disease. Guidelines from British Society of Gastroenterology suggest bone density measurement after 1 year of gluten-free diet in patients who are older than 55 years of age, and in patients who have other risk factors for osteoporosis. Gluten ataxia is one of the most common neurological presentations of celiac disease. Gluten ataxia results from the autoimmune processes damaging Purkinje cells in the cerebellum. Unfortunately, the damage to the Purkinje cells and cerebellar atrophy are permanent and cannot be reversed even with adherence to gluten-free diet. Therefore, it is important to diagnose those patients early and initiate treatment promptly to prevent those harmful consequences. Celiac disease can also affect the liver. About half of newly diagnosed patients with celiac disease have elevated liver enzymes. Hepatitis may be associated with celiac disease. However, in clinical practice, it is usually not recognized as the result of celiac disease, but it is rather associated with other conditions, such as fatty liver. The damage to the liver in celiac disease can progress to cirrhosis and liver failure. Therefore, current guidelines recommend screening for liver function at the time of diagnosis and at follow-up. Celiac disease can impair spleen function. Those individuals have increased risk for infections, especially with encapsulated microorganisms. Although current guidelines don't recommend screening for the spleen function, it is recommended that patients with celiac disease receive influenza and pneumococcal vaccine. Dermatitis herpetiformis is a skin manifestation of celiac disease. It is an immune reaction that results in the deposit of immunoglobulin A in the skin. It presents with skin blisters and extremely pruritic rash. The rash may be present on the extremities, buttocks, or the lower back. The rash may affect a small area or may affect the entire body. Patients with dermatitis herpetiformis should be referred to a dermatologist. It is diagnosed by the identification of IgA deposits on the skin biopsy. After initiation of gluten-free diet, the symptoms should go away. However, it may take a long time for the rash to resolve. The rash symptoms can be controlled with medications such as dapsone or sulfapyridine, short-term only. The long-term treatment is gluten-free diet. Aphthous ulcers and dental enamel defects are the two major oral manifestations of celiac disease. Aphthous ulcers can be severe. They usually resolve with gluten-free diet. Aphthous ulcers can also be seen in other conditions, such as inflammatory bowel disease. Dental enamel defects develop when celiac disease affects children during dental development. In some cases, dental enamel defects can be the only manifestation of celiac disease and should prompt the investigation for celiac disease. Malabsorption of nutrients may occur in celiac disease. Some of those nutrients are proteins, carbohydrates, iron, calcium, zinc, and vitamins. Vitamin and nutritional deficiencies can lead to a multitude of problems, such as deficiency in iron can lead to iron deficiency anemia. Deficiency in vitamin A can cause anemia, reproductive problems, and night blindness. Deficiency of calcium and vitamin D can cause osteopenia and osteoporosis. Deficiency of vitamin E can lead to peripheral neuropathy and ataxia. Deficiency of vitamin K can impair normal clotting and can cause excess bleeding and bruising. Patients should be tested for nutritional deficiencies at the time of diagnosis and should have a consultation with an expert nutritionist at the time of diagnosis and after starting gluten-free diet to make sure nutritional needs are met. Celiac disease is not diagnosed based on the results of a single test. It requires good understanding of clinical manifestations, serology, histology, genetics, and response to the gluten-free diet. American College of Gastroenterology issued clinical guidelines on diagnosis and management of celiac disease. Those guidelines are a good resource for clinicians who diagnose and treat patients with celiac disease. Diagnostic process starts with serologic testing of celiac disease-specific antibodies in patients with symptoms or high suspicion for celiac disease. When positive, the diagnosis must be confirmed with the duodenal biopsy. Patients need to be referred to the gastroenterologist for endoscopy. This ensures that patient receives the accurate diagnosis prior to embarking on gluten-free diet for life. If the serologic test comes back negative, but the practitioner has a high suspicion of celiac disease, intestinal biopsy should be done. Some patients may have a seronegative celiac disease, negative serology with villus atrophy. A combination of patient history, clinical features, serologic testing, and duodenal biopsy is required for making a diagnosis of celiac disease in adult patient. It is important to make sure that patient remains on a gluten-containing diet when testing is being done. American College of Gastroenterology clinical guidelines recommend immunoglobulin A anti-tissue transglutaminase antibody as the first-line single test for detection of celiac disease in individuals older than 2 years of age. It has a high sensitivity of 95% and a high specificity of 95% or greater in untreated celiac disease. Endomysial antibodies test has higher specificity of 95%, but it is expensive, arduous process, and is operator dependent. It is not recommended as a first-line test. In cases where IgA-TTG results are weak positive, endomysial antibodies testing should be added. Patients with IgA deficiency may have false negative results. Therefore, total IgA should be measured together with IgA-TTG. In patients with identified IgA deficiency, IgG-based tests should be used. Antibodies against native gliadin are not recommended as a screening test because of the lower sensitivity and specificity comparing to the TTG IgA and DGP IgA. Combining several tests for celiac disease, such as a celiac panel, is not recommended due to the reduction of specificity, and it may lead to incorrect diagnosis and overdiagnosis. There are typical changes in duodenum which can be seen on endoscopy, such as atrophy of the villi, fissuring, nodular appearance of mucosa, loss of folds, and scalloping of folds. Gastroenterologists will take the biopsy of the intestinal mucosa during endoscopy. Even if endoscopy looks normal, biopsies need to be taken, because the affected duodenal mucosa may have patchy characteristics. multiple biopsies are required, including 1 or 2 biopsies of the bulb, and at least 4 biopsies of the further part of the duodenum. Positive celiac disease serology with villus atrophy confirms the diagnosis. The stages of damage of the small intestine, as seen under the microscope, are graded using Marsh classification. The scale is from 0 to 3, where 0 indicates the least severe changes and 3 indicates the most severe changes. Those changes are villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes. Celiac disease would be present in type Marsh 3. Patient would have increased number of intraepithelial lymphocytes, increased crypt hyperplasia, and villus atrophy. We can see here histologic changes of the intestinal biopsy. In type 0, intestinal lining looks normal, villi look normal. Celiac disease is highly unlikely. In type 1, intestinal lining has been infiltrated with intraepithelial lymphocytes. This can be seen in patients who are on a gluten-free diet but have ingested minimal amount of gluten. It occurs also in patients with dermatitis herpetiformis and family members of celiac disease patients. It can also be seen in other conditions, such as gastroduodenitis, caused by H. pylori, hypersensitivity to some foods, infections, bacterial overgrowth, non-steroidal anti-inflammatory drugs, Crohn's disease, and other situations. Type 2 is rare, but may be seen in dermatitis herpetiformis. Type 3, the crypt hyperplasia and the villus atrophy indicate the presence of celiac disease. People with celiac disease carry one or both HLA-DQ2 and HLA-DQ8 genes. Having one of those genes does not mean, though, that the person has celiac disease or will develop celiac disease in the future. Testing negative for those 2 genes makes diagnosis of celiac disease very unlikely, because 40% of the population carries HLA-DQ2 and/or HLA-DQ8 genes. Testing for those genes is not recommended as the first-line diagnostic testing. Who then should receive genetic testing? Genetic testing should be used to rule out celiac disease in selected clinical situations. For example, in patients who are on gluten-free diet and refuse gluten challenge, or are unable to undergo gluten challenge. Since those patients have already been on gluten-free diet, the antibody testing will not be accurate. Patients who cannot have gastroscopy or are unwilling to have gastroscopy should have genetic testing done. Another option for those patients is video capsule endoscopy. Genetic testing will be useful in situations where there is a discrepancy between serology and biopsy. For example, patients who have negative serology and ambiguous biopsy results, such as Marsh 1 or Marsh 2. Family members of patients with celiac disease should receive genetic testing since the absence of HLA-DQ2 and HLA-DQ8 genes rules out celiac disease in most cases. Can capsule endoscopy be used to diagnose celiac disease in place of upper endoscopy with biopsy? Capsule endoscopy is not a first-line test for celiac disease. It may be done when there is a suspicion for celiac disease, but patient is unable or unwilling to do endoscopy with biopsy. It is a non-invasive method to visualize villi in the small intestine. Pooled sensitivity is 89% and specificity of 95% of celiac disease diagnosis. Useful in complicated celiac disease, can detect stenosis, erosions, ulcers, and lymphoma. Can also be helpful in patients with patchy disease. The weakness of capsule endoscopy is that it can't get a biopsy. Patients who did not receive diagnosis of celiac disease and who already embarked on a gluten-free diet may yield negative serologic testing and negative results from small intestinal biopsy, even in the presence of celiac disease. The specific serologic and histologic changes which are present in patients with celiac disease don't normalize right away after starting gluten-free diet, so patients can still test positive if they have been on gluten-free diet for less than a month. Therefore, serologic tests and biopsy may still be used to diagnose celiac disease. But if those test results are negative in patients who followed gluten-free diet for less than a month, they cannot be used to exclude celiac disease. HLA-DQ2 and DQ8 genetic testing is not influenced by gluten-free diet and can be used to exclude celiac disease in patients already on gluten-free diet. The absence of HLA-DQ2 and DQ8 genes rules out celiac disease in most cases, so there is no need for further testing. If HLA-DQ2 and HLA-DQ8 typing is positive, consider gluten challenge. Gluten challenge can be used in those patients who are suspected to have celiac disease and are already on gluten-free diet. In gluten challenge, patients who have been on gluten-free diet return to gluten-rich diet in order to mount antibodies and induce villus atrophy to confirm the diagnosis. It must be done under clinical supervision and only in those patients who can safely ingest gluten. Although, historically, the requirement was ingestion of 10 grams of gluten per day, which equals about 4 slices of bread, for 6 weeks. The recent studies found that if patient ingests more than 3 grams of gluten per day for 2 weeks, or 10 grams of gluten per day for 18 days, it can induce serologic and histologic changes to confirm the diagnosis. Since celiac disease presents with a variety of symptoms, who should be tested and when? It is easier to think about testing those patients who present with classic gastrointestinal symptoms, such as bloating, diarrhea, and weight loss. But it is more challenging to think about celiac disease and test those patients who present with non-classical symptoms, such as iron deficiency anemia without explanation on endoscopy, vitamin or nutrient deficiencies, or patients with severe or persistent mouth ulcers. Patients at higher risk should also be tested. They are patients with type 1 diabetes, autoimmune thyroid disease, irritable bowel syndrome, and first-degree relatives of people with celiac disease. Celiac disease testing should be considered in the following patients: patients with metabolic bone disorder, premature osteoporosis and osteopenia, unexplained neurological symptoms, particularly peripheral neuropathy or ataxia, unexplained subfertility or recurrent miscarriage, persistently raised liver enzymes with unknown cause, dental enamel defects, Down syndrome, and Turner syndrome. Some individuals may have other gluten-related disorders, such as non-celiac gluten sensitivity in the absence of celiac disease. It is important to differentiate non-celiac gluten sensitivity from celiac disease and make the right diagnosis, since celiac disease patients must adhere to strict gluten-free diet for life. Adhering to strict gluten-free diet is very difficult and cumbersome. In case of non-celiac gluten sensitivity, patients may adhere to gluten-free diet to control their symptoms. Condition can be transient and may go away with time. The mechanism of non-celiac gluten sensitivity remains unknown. Non-celiac gluten sensitivity can present similarly to celiac disease, with intestinal symptoms, extraintestinal symptoms, or both, which are triggered by gluten ingestion. The clinician should suspect non-celiac gluten sensitivity in patients presenting with those symptoms, when symptoms disappear after removal of gluten from the diet. Those symptoms are similar to celiac disease and wheat allergy. Therefore, clinicians cannot diagnose non-celiac gluten sensitivity on symptoms alone. But unfortunately, there is no serologic or histologic test for non-celiac gluten sensitivity. The intestinal mucosa appears normal on the intestinal biopsy. At this time, non-celiac gluten sensitivity is diagnosis of exclusion, since there are no screening tests for it. The healthcare providers should assess patients' symptoms after 1 week of adhering to gluten-free diet versus 1 week of not adhering to gluten-free diet. The only treatment available is strict gluten-free diet for 12 to 24 months, and after that time, patients should be retested if they can tolerate gluten. Wheat allergy is an immunoglobulin E-mediated allergic reaction to wheat proteins. It is more common in children. Allergic reaction occurs soon after wheat ingestion. It can also occur after inhaling wheat flour. Patients may have symptoms such as urticaria, angioedema, swelling and itching of the mouth, throat, and skin, watery eyes, nasal congestion, difficulty breathing, nausea, abdominal pain, and in severe cases, systemic anaphylaxis. The diagnosis of wheat allergy is based on skin prick tests, specific immunoglobulin E in vitro assays, and challenge tests. The treatment is wheat avoidance and antihistamines for symptoms of allergic reactions. In severe cases of anaphylaxis, epinephrine is given. Currently, there are no medications available to treat celiac disease. Gluten-free diet for life is the only effective treatment. Patients have to avoid foods that contain gluten. Gluten-free diet has been popular recently, and it's estimated that there are about 3 million people in the United States who do not have celiac disease but remain on gluten-free diet. Patients should feel better within days to weeks on gluten-free diet. Intestinal mucosa will start healing, but it will take longer, however, for serologies and villus atrophy to normalize. Decrease in antibodies can be seen within months of gluten-free diet. Adherence to gluten-free diet will lower the risk for increased mortality and complications of celiac disease, such as malignancies. Treatment with gluten-free diet will also improve bone mineral density and nutritional deficiencies. Gluten is a protein found in wheat, barley, and rye. People with celiac disease should strictly avoid all products containing wheat, barley, rye, and their derivatives. All varieties of wheat have to be avoided: einkorn, emmer, spelt, and kamut. All forms of wheat, all flours have to be avoided as well. The examples are listed here. Barley, including malt, rye, and triticale, have to be avoided as well. Oats are a source of fiber, vitamin B, magnesium, and iron, and can improve nutritional deficiencies in people with celiac disease. But oats may be contaminated with gluten from other grains during growing, harvesting, and processing, and may be unsafe. Patients with celiac disease may only consume oats that are pure and not contaminated. Those oats will be labeled gluten-free. There are some people with celiac disease who may be intolerant to pure oats. Therefore, oats should be introduced with caution. There are a plethora of naturally gluten-free foods. Patients are encouraged to eat those foods and minimize consumption of processed foods. Some examples are provided here and include meats, poultry, fresh fish and shellfish, fresh fruits and vegetables, 100% fresh fruit and vegetable juices, milk, butter, eggs, lentils, seeds, peanuts, tree nuts, honey, distilled alcoholic beverages, for example, vodka or gin. Gluten is removed during distillation process. Wine is gluten-free as well. Patients with celiac disease can choose from many grains and flours that are gluten-free and safe. Many of those grains are staples of the American diet, for example, corn, rice, beans, and soy. Quinoa is becoming more popular and available. Some examples are amaranth, teff, sorghum, millet, buckwheat, arrowroot, wild rice, sago, potato, tapioca, beans, Indian rice grass, and gluten-free oats. Following gluten-free diet, however, is difficult and cumbersome. It is difficult to be completely gluten-free because many commercially available foods may be a source of hidden gluten. Patients have to be constantly vigilant and careful to avoid incidental exposure to gluten. They have to carefully read food labels. The pictures here are some examples of food that may contain gluten, such as beer, sauces, gravies, and croutons. The other problem is cross-contamination of foods with trace amount of gluten. Patients may be inadvertently exposed to the minute amount of gluten when eating out in a restaurant. For example, the food may be contaminated with gluten in restaurants when the same toaster is shared for wheat bread and gluten-free bread. The accidental exposure to gluten may be harmful, as if the patient was consuming gluten. Eating out may cause anxiety in patients who fear food contamination. Some medications and supplements can also be a source of hidden gluten. Gluten-free foods are more expensive comparing to the regular foods, which make it difficult for lower-income patients, and as a result, they may not be compliant with the diet. Failure to adhere to gluten-free diet may cause complications, such as malignancies and increased mortality. Labeling of gluten-free products and ingredients may be confusing to some patients. Gluten-free term indicates that food may contain a minimal amount of gluten that should not cause damage. 10 milligrams of gluten per day is considered to be safe. FDA allows packaged foods that contain less than 20 parts per million of gluten to be labeled gluten-free. FDA reports that 20 parts per million is equivalent to 20 milligrams of gluten per 1 kilogram of food. Patients with celiac disease should be referred to an expert dietitian who is knowledgeable about celiac disease to learn how to navigate through gluten-free diet and make healthy substitutes for grains rich in fiber and nutrients. Patients need to be taught how to avoid contamination at home and when eating out, how to identify foods with hidden gluten, and also how to read food labels. At the time of diagnosis, patients need to be screened for vitamin and nutritional deficiencies, particularly vitamin D, B12, folate, and iron. Pneumococcal vaccine should be offered since patients are at the higher risk for community-acquired pneumonia. Untreated celiac disease is associated with low bone mineral density and increased fracture risk, therefore, patients need to be screened for osteoporosis. After initial diagnosis, patients must be followed up regularly to monitor the symptoms, check adherence to gluten-free diet, and to assess for complications. Monitoring includes verification of antibody normalization and healing of the intestinal mucosa. The normalization of antibodies does not necessarily mean the healing of intestinal mucosa. The only way to verify healing of the mucosa is through the biopsy by the gastroenterologist. Annual follow-up is recommended. There are about 20% of patients treated with gluten-free diet who will have persistent or recurrent symptoms. It is very important to confirm the initial diagnosis in those patients. If the initial diagnosis is confirmed, the most common cause of non-responsive celiac disease is inadvertent gluten ingestion. Those patients should have a consultation with a dietitian knowledgeable on celiac disease to ensure elimination of gluten from the diet. Other possible etiologies need to be ruled out as well. They include other food intolerances such as lactose or fructose, irritable bowel syndrome, microscopic colitis, pancreatic insufficiency, and small intestinal bacterial overgrowth. Refractory celiac disease can be diagnosed in the presence of persistent or recurrent symptoms of malabsorption and villus atrophy in patients who follow strict gluten-free diet. Refractory celiac disease can lead to increased mortality and intestinal lymphoma. Celiac disease patients often consume unsafe amount of gluten while on gluten-free diet. Treatment of celiac disease with gluten-free diet demands constant vigilance to avoid accidental gluten contamination. Is there anything that can be done for celiac disease patients that will help them if they accidentally ingest gluten? There are more than 3 million celiac patients in the United States, about the same number in Europe, and 15 million in the world. The third Gastroenterology Regulatory Endpoints and Advancement of Therapeutics Conference, sponsored by the U.S. Food and Drug Administration in 2015, announced the necessity to develop therapies that address symptoms which occur after accidental gluten ingestion. Currently, there are several experimental, non-dietary therapies for celiac disease in clinical development. Larazotide acetate is potentially the first drug to market for celiac disease. It is entering phase 3 trials. It is a capsule orally administered before each meal. It is indicated for patients who are on gluten-free diet but still have symptoms of celiac disease. It is not systematically absorbed. Latiglutenase is a promising new drug in late phase 2 studies. It comprises of 2 enzymes which work in the stomach to break down the large gluten fragments so they are no longer immunogenic. Latiglutenase is not systematically absorbed. It comes in a powder form, needs to be diluted, and taken orally with meals. It is to be administered as an adjunct to gluten-free diet. Vax2 is the first peptide-based therapeutic vaccine for celiac disease. It reprograms the T cells which respond to gluten. Phase 2 clinical studies will start in the second half of 2018. This vaccine works on the same principle as allergy desensitization therapy. The ultimate goal of the vaccine is to restore a long-term tolerance to gluten. The vaccine has the potential to replace gluten-free diet. The next few slides will review a case study of a patient diagnosed with celiac disease. A 51-year-old Caucasian male with no significant medical history presents to the primary care provider complaining of increasing fatigue, lack of energy, brain fog, difficulty concentrating, and tiredness. He has had those symptoms for years, but now he feels they are getting worse. He feels there is something wrong with him, but cannot pinpoint the cause. During last year's workup, healthcare providers suspected gastrointestinal bleeding due to low hemoglobin, iron, and ferritin, and referred patient for colonoscopy. Colonoscopy was negative. Patient was instructed to increase foods high in iron in his diet, which he has done for a year, but he is not feeling any better. He does not offer any other complaints, does not have gastrointestinal complaints, and denies any bleeding. Patient's BMI indicates patient is overweight. There is a misconception out there that patients with celiac disease are underweight. On the contrary, adults with celiac disease may be overweight, as in this example, or even obese. His blood work reveals low hemoglobin level, very low ferritin and iron levels. Also, patient is deficient in vitamins B12, D, and folate. In addition, total cholesterol and HDL cholesterol are low as well. These findings suggest that patient may have a problem with absorption of nutrients and vitamins, particularly since his colonoscopy was negative. Clinicians should suspect celiac disease in unexplained iron deficiency anemia. Low ferritin and low cholesterol levels were found in patients with undiagnosed celiac disease by the Mayo Clinic researchers in their community-based studies. The clinician suspects malabsorption problem in this patient and orders celiac disease serology. First-line serologic test. Tissue transglutaminase IgA comes back positive in this patient. Results indicate greater than 100. As discussed earlier, the gold standard of diagnosis of celiac disease is confirmation of serologic findings with endoscopy. During endoscopy, gastroenterologists noted atrophic intestinal mucosa and fissuring, seen on the picture here. Findings indicated possible celiac disease. Biopsies were taken, patient was started on gluten-free diet, and advised to follow up biopsy results. Biopsy results indicate marked villus atrophy and increased intraepithelial lymphocytes, consistent with celiac disease. Once diagnosis was confirmed, patient was referred to a celiac disease expert dietitian. Patient received detailed instructions on strict gluten-free diet. He was screened for osteoporosis with DEXA scan, which was negative. Pneumococcal vaccine was recommended. It can be seen here that with gluten-free diet alone, without any supplements, celiac disease serologies are stabilizing, and iron, ferritin are normalizing. In addition, his HDL cholesterol is normal. 2 years after strict adherence to gluten-free diet, patient is feeling much better. He is no longer fatigued, does not feel tired, he has more energy, and brain fog is no longer present. After 2 years of gluten-free diet, his transglutaminase IgA antibodies are normal. Patient follows up now on an annual basis. The repeat endoscopy will be done next year as per his celiac disease specialist to make sure his intestinal mucosa recovered. Included here are some additional resources for patients and healthcare providers. They can find a lot of helpful information about celiac disease, gluten-free diet, and support groups, among other things. Celiac Disease Centers and Mayo Clinic are the leading centers for diagnosis, treatment, and research of celiac disease. Gluten-Free Drugs website is a helpful source of information on gluten-free drugs. Gluten-Free Watchdog website, found by Tricia Thompson, provides information on regulations and results of testing of gluten-free foods. I want to thank everyone who helped me with making this project, including my professors from Evelyn Spiro School of Nursing at Wagner College, Elaine Marchi, the research scientist, and special thanks to Dr. Green from Celiac Disease Center at Columbia University for verification of the presented content. I also want to thank April Lillard for her narration and the patient who provided his medical information, serology, and images of endoscopy and biopsy for the case study. The next 6 slides will contain the references and additional references, including the references of images used in the presentation.